Hello to the viewing and listening public. My name is Stacey Carmichael and welcome to this special program on COVID-19. Now today we're joined by Dr. Carpen and he will be giving us some information on COVID-19. It's nice having you on the program, Dr. Carpen.
Thank you very much for having me.
You're welcome. Before we get into the meat of the matter, could you just give us a brief introduction about yourself so that the public could know, who you are, your specialty?
I'm Dr. Mahendra Carpen. I'm an interventional cardiologist by training. But before we get to interventional cardiology, of course, you have to do internal medicine and your background training. And I'm currently the head of medical services at the Georgetown Public Hospital. And it is within my department that we see and manage the COVID-19 positive patients who are admitted to the Georgetown Public Hospital.
Thank you so much. Now, that was a brief introduction. Now, Dr. Carpen, tell us about your role as a cardiologist and how critical this role is in the fight against COVID-19.
So as we go on more and more into this pandemic, we are finding out that the COVID-19 disease is more than just a bad flu that affects the lungs and causes shortness of breath. We are finding out that COVID-19 patients can develop all kinds of problems, chief among which are the lungs, the heart, and the kidneys. All the major organs can be involved. It can also cause strokes in patients who have otherwise not had any major known risk factors for these conditions. My role mainly at Georgetown Hospital is more as in a supervisory administrative capacity as we deal with COVID and the team that actually manage these patients on the ward, in the triage area, and all other areas of support.
We do know a little bit about pre-existing conditions. Persons with pre-existing conditions, they can be severely affected by COVID-19. Could you expound on that, how difficult it is for those persons and some of the challenges that would pose for them health-wise?
Yeah, that's a very important question, and we were first made aware of this on a more international scale. We have read the literature, we've seen the research. Patients who have particular chronic non-communicable diseases as their background illness. These patients tended to be doing worse. They have a higher death rate, a higher hospitalization rate, more need for ventilation, and longer hospital course. When we started seeing patients, and as we see more and more patients, we are recognizing that those same parameters hold true for Guyana. Patients with high blood pressure, patients with diabetes, patients with chronic lung disease, other autoimmune or immunosuppressive disorders. These things can cause increase in mortality and morbidity in the COVID-19 patients.
Now that you've mentioned all these complications that can follow for those persons with the pre-existing conditions, what should they do, those persons who move with these existing conditions, what should they do to protect themselves against the virus?
It is very important that the underlying conditions are managed tightly. If you have diabetes, make sure the diabetes is well controlled. The high blood pressure is well controlled. Make sure you have exercise, the diet is right. All the basic, simple things that we know that make a difference in your baseline condition, they also work in COVID. And of course, as it relates particularly to COVID, the measures of social distancing, sanitization, washing your hands, keeping your mask on when in public, those are all very useful things and help to prevent the spread of disease among population.
Now, what should persons do if they suspect they may have been exposed to COVID-19? What are some of the immediate steps?
The first thing is to make sure that you're going to be away from an exposure. But if you can't manage that, and if you're inadvertently or accidentally exposed, there are things you can do. Make sure you wash up, make sure you keep your mask on, make sure you isolate yourself from especially elderly relatives and co-workers and people around you, and get yourself tested. Now, at the time of exposure, you are probably not likely to get a positive test. The tests become positive between day 3 to day 5, and we will see that on the graph where I'll show you. Now, most people around that time will not develop any significant symptoms, but once they have been exposed, they can develop the infection without the symptoms, and they can actually pass it on to someone who can become much sicker. And these are the people we talked about earlier with the comorbid conditions, the diabetes, the hypertension, the older relative, people with underlying lung disease, etc. So that is the real danger. The problem with COVID is that most of the infected people do not know that they're infected. And so they carry on mingling with others who are more susceptible for adverse outcomes. And that is what is most dangerous about controlling this pandemic.
Thank you, Doctor. Now, moving on a little bit, we want to talk about plasma treatment for recovery from COVID-19. How did this originate, and where are we locally with those trials?
Great. So that's a wonderful question, and this is one that we at the Georgetown Hospital, we actually take pride in this being one of the pioneering institutions. Now, convalescent plasma, the benefits of this has been seen way back in history when we were dealing with the Spanish flu and other pandemics. What the basis of this is that if you get an infection, your body tries to fight it off. And it does so by making what is known as antibodies. These are your own native defense soldiers. Now, those generally fight off the infection, and they can remain in your blood. So you are well, but you still have the defense mechanism. So what we do is we take the blood from recovered COVID-19 patients, assuming that they have these defense mechanisms or antibodies in sufficient quantities. And then we take that and we give it to patients, of course, who are compatible. It's just very similar to blood transfusion. You have to transfuse A with A, B with B, etc. So we then process it in the normal sterile manner that is compatible with transfusions. And we give it to people who are sicker and in hospital and require more than antibiotics or other medical management strategies that we have. And so far, we have been able to use this science at the Georgetown Public Hospital. I believe it's the only hospital within the country that has employed this strategy, and among the very, very few in the Caribbean and CARICOM that actually was able to successfully collect, process, transfuse, and maintain a good safety profile for the use of this therapy.
Now, I'm not sure if I'm totally accurate, but there was something being touted about 1 week for the results from testing. Could you clarify that for me and just explain how testing is being done, and also what are some of the measures being taken now to get those test results back faster?
Yeah. In our current system, testing has 3 components. 1, the machine, 2, the test kits, and 3, the human resource or the technicians, the personnel. When we first started our response to COVID-19, we had the machines, but some we didn't know we had. We had limited number of test kits, and therefore we had limited number of tests being done. I believe we're very satisfied with doing maybe 10, 15, 20 tests a day, which is very, very much below the capacity. And at that level, we didn't need more human resource. However, as we got deeper and deeper into the pandemic, the numbers started rising and more patients started getting tested. So we have the machine, we got more test kits, but we didn't have trained personnel to do it. The process of starting the training was only begun and implemented last week. There are two components to training: an online or reading part, and then there's a practical part. And we're just over halfway there. And by the end of the week, we should have more teams who are trained to conduct this test. So we will likely move from about 80 to 90 tests per day, which is done over a 8-hour period, and go to 3 shifts of 8 hours that can triple that number, almost 300 tests per machine per day. And this is where we want it to be, and this is how we're going to clear the backlog and actually test the appropriate numbers of patients. You may see our numbers have gone up recently. There are two things for that. One, people are a little less careful. They're more complacent these days because, the fatigue has gotten to people. They've been locked up. They've been told about social distancing. They've been told about don't leave your house, don't do this and all. So after 5 months, 6 months, people are exhausted mentally about it. And that has led to a sense of complacency. In addition, we have started to do a lot more testing. So if you test more, you will find more. We have, I believe, now 700 plus cases. And the more we test every day, the more cases you're going to find. Now, we have 2 strategies mainly to focus on. The imported cases, how to control that, and that's your borders and your airports, etc. And of course, there's a community spread. How do you control that? That's your social distancing, your early intervention, your education, etc. But it's very hard to tell somebody stay home when there's no food on the table. So this is how we have to strategize as a country to move forward. If you're going to stay home, you're not going to have to choose between dying from COVID or dying from starvation.
Now that you've mentioned more testing and the persons being more careful, what are some additional things that people can do to help the healthcare workers in the fight against COVID-19?
So what we would like in the health sector, we would like to see people wearing masks. We would like to see them washing hands. We would like to see them maintaining social distancing. We would like to see less crowds, less gathering. I'm driving around Georgetown going to and from work, and I see a lot of people on bars and hangout spots in crowds of 20, 30, 40. Nobody's wearing masks. They're all, having a good time, which is, it's living, but it's a little bit irresponsible because a lot of those people have older family members that they go home to. They have people that they interact with who are at high risk. These are people who have, the diabetes, hypertension, all of those comorbid conditions that we talk about that can cause increased mortality and increased morbidity.
Now, Dr. Carpen, you want to show us demonstration of how this COVID-19 works, the science behind it all. Could you just give us a demonstration of that so the public can get a better understanding of how COVID-19 works?
Absolutely. I'll be happy to draw it on the whiteboard for you. So let's look at the time course and the natural history of COVID-19. A simple graph will help us to understand severity of illness, and this is time, okay? From day 0, day 5, day 12, and day 28. So from 0 to 1 month. You put in maybe 2 weeks here, 14 or 15 days, right? When you get infected, there's a climb in the viral load, and it starts to disappear by about a month. In this first week, this is what we call the incubation period. That's my fancy handwriting, so please don't laugh. This second part here, up to about 2 weeks, this is where patients start to develop symptoms. And why do they develop symptoms here, because when you get an infection, your body now starts to fight this infection. And in the COVID scenario, it is the body's reaction that is now starting to produce fever and those other symptoms. So you have this immune reaction that starts, and it gradually starts to rise and then comes out of whack after 2 weeks for certain people. At the same time, patients' oxygen saturation, usually at 100, 98 to 100, at around the 2 weeks' time in the sick patients, it starts to drop. And at some point, it disappears. Of course, the majority of your patients will be between these first categories here, right? Here is the early pulmonary stage, and this is the late stage. The danger of this condition is that all of here, where there's incubation before symptoms, this is where patients or people can pass it on to each other. And this is the danger of this condition. So when we talked about being exposed and who you can put at risk, this is the greatest risk here, because you don't know what's happening here. And here, the majority of people have mild symptoms, and they're thinking it's the flu or their allergies or something else, and they could also pass it on in this period here. When you get to pulmonary stages and your oxygen saturation starts to drop and your inflammatory response starts to increase, that is when you get the dangers happening. That's when people are admitted to hospital and they need intensive treatment. And of those patients, the majority of people, 80% of them will be in these first two categories. The rest of them will be in these two. Only about 5% will end up in late stage, and 1 to 2% unfortunately will not make it. So our job is really to catch people before they get to this phase, because once the inflammatory response starts to go up, this is when people get into real trouble. They need ICU care and they can die, right? So this is a simple representation on a graph. Hopefully it makes sense to understand the danger of this condition, because most of the patients are in this area here that they can actually cause problems to others who they come in contact with.
So there you have it. That was Dr. Mahendra Carpen. He gave us a brief rundown of COVID-19, what are some of the things taking place at the Georgetown Public Hospital Corporation, the science behind COVID-19, and some precautions that we could take. Dr. Carpen, I want to thank you very much for being on the program.
My pleasure. Thank you for having me.
And thanks for the information that you provided to the listening and viewing public.
My pleasure. Thank you for having me.
You're welcome. Thank you.